strong, which you may know some of my various colleagues that you've seen over the years. And this really came out of a shoulder class that has been taught for the last few years, like Terry was saying, and we do that over 3 sessions. So today I'm giving you the quick and dirty understanding of what are the big things we think about with shoulders. And this is actually an area where there's been quite a bit of research over the last few years, looking at what are the real factors that cause the most damage. And I think what's been really interesting is that we used to think a lot about wheeling, and wheeling is really important, but what they've actually found is it's things like heavy lifting and transfers, which I'll spend quite a bit of time on today. Not to say that wheeling's not important, but there are other factors as well. So yeah, we're going to try and go through this relatively quickly, and I really encourage you to either write down or, Terry, you might part of the way through just stop for questions, because it's a lot of content that we're trying to get through, and maybe we'll stop at a couple of different times just to ask for questions. Yeah. So just a general summary of what I'm going to be talking about today. We'll start with anatomy, just looking at how the shoulder's built, posture, because that's a really important part of the big picture, aging, and how that affects your shoulders, and how do we make this better or prevent shoulder pain from happening. We'll also talk a little bit about stretching and strengthening, although we won't have time to go through the program together today. And then some questions that I get a lot from my patients are things like imaging and injections. So what does it mean when my doctor sends me for this or that or the other thing? What are they looking for? What kinds of injections are available to me? And then some considerations if surgery is something that's on the horizon or has been mentioned to you. So the shoulder is actually a really complex joint. It's actually a collection of joints, which I'll go through in a second, but I just wanted to point out some really important structures that you can see there. The rotator cuff is something we're going to be talking about a lot today because it's a structure that tends to get hurt quite a lot. But some of the other things you might have heard of is the little blue thing in the middle there is called the bursa, and that's a little fluid-filled sac that acts like a buffer between your bone and your muscle. But sometimes you hear of something called bursitis, which can be really painful and can be part of shoulder dysfunction and discomfort. But yeah, I just wanted to say that it is a really complex thing. So it's not just the joint you think of. There's also many joints involved, and there's over 20 muscles involved here as well. One of the things I always like to do is compare the hip joint, which is the one you see on your left, to the shoulder joint, which is the one you see on your right. The hip joint is what we call a ball and socket joint. So it's very deep. So if I sort of think about the hip, it's a ball, which is my fist right here, and it's a socket all that really encompasses it with bones. So bones are really, of the hip are quite stable. But if you compare it to the shoulder in the bottom right-hand corner, what you can see is that it does have the ball similar to the hip, but the socket is not really a socket at all. It's somebody described it. It's like a saucer. It's very flat. And what that allows is that you can move your arm, you can reach overhead, you can do all the things that are great to do with your shoulder. But what it means is that it's less stable using bones. And so what that forces your rotator cuff and the other muscles to do is keep it stable using muscles and tendons and ligaments. But those structures are more prone to wear and tear. So like I said, the shoulder is not just one joint, it's actually 4 joints. I won't go through them in too much detail, but it's the one that attaches your shoulder blade to your rib. We actually consider the ribs and allows that to move that. We consider that a joint. It's your sort of classical shoulder joint, the ball and socket. And it's also the 2 ends of your collarbone as well. So if any one of those is having a problem, it often causes a problem in the other ones. So we often have to think about, if you're having dysfunction in one spot, it's not just dysfunction in that spot. It causes dysfunction throughout the shoulder complex, as we call it in our little medical world here. So the rotator cuff. This is something that many of you might have heard of. So you go and you get some sort of imaging done and they say, oh, you have a rotator cuff tear, or you've got some tendinitis in your rotator cuff, or tendinosis. There's lots of different words, but really what it means is that one or more of these muscles is affected. And it's four little muscles that go from your shoulder blade onto the head of your arm bone, so what we call your humerus. And each of those muscles is subject to a lot of problems. I would say that the supraspinatus, which is the one kind of on top here, I'm not sure if you guys can see my pointer or not, but it's the one that kind of comes through this sort of tunnel, as I like to call it, that is made by your collarbone and the bone that's here called the acromion. And it comes through, and it's very important for stability of your shoulder joint. So when that gets into trouble, that's when you start to have quite a bit of pain, when you can have some issues with the shoulder being really have a lot of problems with range of motion as well. But I think the number one thing to know about the rotator cuff and why it gets hurt so much is that as a wheelchair user, you're trying to use your arms to do things that other people use their legs to do. And I know that's a sort of a silly thing to say. It's kind of true. You're putting a lot of pressure through an area where there's lots of little small muscles that are not really meant to have that much pressure put on them. And so over time, those muscles can break down. So the reason the rotator cuff is so susceptible to injury is that for a few reasons. If you're quadriplegic, what we often say is that you have muscle imbalance. So some of your muscles are actually quite strong and other ones may not work at all or can be quite weak. And so what that means is that the shoulder can be pulled in one direction and not pulled in the other. So there's not a balance of muscles. The supraspinatus, like I was saying, tends to get pinched, which can cause, like I said, a tendinitis or something of that nature. And it really is dependent on where your shoulder blade is in space. And that's kind of a hard thing to imagine. But if your shoulder blade, sorry, I'm just going to go back to here. If the shoulder blade ends up sitting very high, then there isn't, and that's somebody who sits with their shoulders in their ears, I like to call it. So somebody who sits and they have a lot of neck pain or they're having a lot of trouble, and all of a sudden their shoulders start to creep up into their ears. And what that means is that doesn't give a lot of space for this little muscle to move around, and it starts to get pinched in between all of the different bones and ligaments and stuff that are there. So what often happens is that you start to lose your strength or you have an injury of some kind. The shoulder blade gets out of position, the tendon has less space, and all of a sudden you're getting this pinching, which is causing pain. And so that's one of the major causes of shoulder pain that we see. It's not the only one, but I would say that many wheelchair users, when we look inside their shoulders using either an MRI or an ultrasound, we'll talk about those things later, this is an area where they have trouble. So I often like to make people think about this a lot because it seems silly to say, but we kind of almost let shoulder pain creep up on us. So how many of you can kind of nod your heads to me about having had a bad night's sleep because of shoulder pain? Yeah, good. Yeah, so I mean, not good, but it's something that we all can kind of understand. And then other things that you sort of, again, can kind of creep up on you is before maybe you could do something for hours at a time, and now you really need to take some breaks. Some people, it's that they can't transfer very well. We'll talk, as I said, a lot about transfers a little bit later. And also, even something as simple as eating can actually start to feel like it's a real shoulder exercise if your shoulders start to get into pain. What we know about people with spinal cord injury, and that's whether people are able to walk or are in wheelchairs, is that they often suffer shoulder pain. And this is especially true of people who are using wheelchairs. So one of the questions I get asked is, man, I felt a really sharp pain, but I wasn't sure if I should go to my doctor. So here are the cases that I'll tell people it's time to go to the doctor. If you fall and you get new sharp pain, and it's really not going away pretty immediately, I would go and just get an x-ray to make sure things aren't broken. So that may be a case where you go into your family doctor or to emergency or urgent care just to make sure that nothing's broken. Because if you're moving around a broken bone, obviously that's not very good. If the pain is waking you up at night or you're really not able to sleep, that's another sort of red flag. If you're not able to move your arm at all, or if you're starting to notice new numbness or weakness, whether that's in your arm or your shoulder. So those are all reasons where I usually tell you, you know what, it's time to get some, and let's take a closer look at this before we start trying to strengthen something that might have something else going on that we don't know about yet. So how do we sort of prevent and manage shoulder pain? Because, you know, this is a hard thing to deal with. If you're going through a lot of shoulder pain, you know, this can really affect your life. So the first thing I always say is get yourself educated, which you're all doing right now as a start. So that's really good. The next thing we're going to talk about is posture, because I think if you put the shoulder in the right position, you go a long way to getting it set up for success. And part of that, of course, is how you set up your wheelchair. Making sure that you're wheeling smart and not so much hard. Making sure that your transfers are done well. And changing your environment, so that might be your home or your office, for long-term health. And then, of course, I am a physio, so I have to say that it's a good idea to do some exercise and to stretch. Terry, is it possible to unmute people and I could just see if there are any questions as through all that? That was a lot of information.
Yeah, I can totally do that. I kind of have to do people one by one because there's so many people. But Jeff, how about you? Any questions?
Lots of questions.
Oh, geez.
Yeah.
Good.
I'm completely numb in both hands.
Mm-hmm.
And I believe it's my shoulders.
Okay.
I have a torn rotator cuff on one side. I don't know about the other side.
Right. So, yeah, I mean, I think you're sort of hitting on a really important point that if you're starting to notice new symptoms that you haven't had checked out, that's a good reason to sort of approach that with your doctor. You know, I'm not saying that they may be able to fix everything, but we should at least know what's going on in there. That's a really important thing to do. Sometimes imaging is more about just kind of understanding what's going on as opposed to knowing exactly what we need to fix. But it sounds like you may have already had your shoulder assessed on one side, so it might be a good idea if you're having symptoms on both sides to have a look.
Going tomorrow.
You're going tomorrow?
Yeah.
So it's shoulder week for you then.
Yes.
Yeah, so I think I'll talk about this a little bit later, but I think it's important to kind of...
like I'm getting so much pain, my tummy gets upset.
Yeah. I mean, it's really can affect your life. And I think, you know, the good news is that what we find is that regardless of what your imaging says, that we know that with some simple changes, we often are able to decrease your pain. You know, and I think that that's a few things I'll talk about as we go along today. Some of them are straightforward things like that you may have already heard of. Other ones might be new to you. So we'll kind of go through a few ideas of ways that you can kind of lessen the strain on your shoulder and also trying to make it stronger, even in the context of having damage to the structures. Because that's the kind of good news, is that they've done lots of research on this because it's such a huge issue for people with spinal cord injury. And even with pretty bad rotator cuff tears, people with small changes are able to decrease their pain. Now, whether we're going to get rid of it all, that is a different question, but certainly there are a few changes we can look at to try and reduce the pain and hopefully improve your life a little bit.
Awesome. I do see that Lisa has her hand raised there, so I'm going to unmute you. Lisa.
Hi. I'm just wondering, I'm a paraplegic and I use my wheelchair part-time, but I'm also studying to be a sign language interpreter. And when you were talking about muscles kind of like degrading over time, I can't remember the exact words you used. Like, I have this fear that eventually my muscles will just give out. And I'm wondering if a muscle can kind of last for your lifetime, even though I am using a wheelchair, if I am careful and keep it in shape, or if eventually like just some injury is inevitable. What's your take on that?
That's a really good question. I mean, I would say that I tend to see people come to see me because they have problems. So I don't often see a lot of people who are have no problems. But what I've found is that the keys to keeping yourself healthy as time goes on is trying to reduce the amount of stress you put on the shoulder, strengthening like you just talked about, but also making sure that you're not gaining weight is a really big one as well. It sounds like something that, we always, every healthcare professional says, but in terms of reducing stress on your shoulders, especially during things like transfers, if you're doing any sort of standing or walking, those sorts of things, if you can reduce the chance or like try and keep yourself at a healthy body weight, that is a huge deal. So those are the kinds of things, and I'll talk about that as we go along. There are people that I have met that have gone their whole lives and have never had problems. What's interesting is that I had one and he said, oh, I didn't actually have a problem, but they had to do imaging for a different reason. And they actually showed that he had quite a bad rotator cuff tear. So I thought that was really interesting because he said, I've never had any pain. And yet when they looked at the imaging, which is something I tell people a lot, is that imaging is just one tool. If you don't have pain or any issues with your day, don't worry too much if your imaging says that you have a problem. So yeah, sorry, I'll go through this later, but basically imaging and pain are not always directly related, which is kind of interesting to me. I'm not sure if I understand exactly why that's true. But yeah, I think the things you can do are those things that I just talked about. But yes, there are people out there. They tend to be people who've kept themselves in good shape, haven't put on very much weight, and are careful to not overly strain their shoulders, and have kept doing their stretching and strengthening.
Okay, yeah. I mean, it's recent that I've had shoulder pain. I'm not sure what it is, and so I feel like I should probably go see a physio just to stay on top of it. I know that top muscle back there that you were talking about, it started with an S, I think.
Supraspinatus, probably, yeah.
Yeah, that one hurts quite a bit sometimes. So yeah, I'm gonna go in and get it checked out. I wanted to have a little bit of hope.
Oh yeah, absolutely. It's certainly possible. It's hard, and not everybody will do it. And sometimes even with the best, doing your best, it's not possible. This is a hard job your shoulder's trying to do now that it didn't have to do before and was kind of not really built for. So, I tell people to try not to take it like personally if your shoulders have problems. This is not always about you. Sometimes it's just a hard job that it's trying to do. I think especially as women, it's a little bit harder because we're not as, we don't put on muscle as easily. So I often say that it's often a really good idea as a woman to really be a little more, I don't know if aggressive is the right word, but continuing to make sure that you're strengthening the shoulders, maybe a little more than a guy who has, testosterone, which seems to grow muscle just all by itself, might have to do.
Okay, thanks. I'm looking forward to hearing all the ways that you're going to talk about doing that. Thank you.
Awesome. Thanks, Lisa. I think we're got everybody, I hope. So
awesome.
Why don't you go on?
Okay. So I kind of talked about this. This is the kind of things that we're going to talk about today. So posture. So this is kind of one of those, there's the ideal and there's the reality. So I'll talk about what we'd like to see in terms of the ideal. One thing that's really important to know is that neck posture and neck pain and shoulder posture and shoulder pain are very much related. So if you have a neck that's sitting in the very funny place, I often find that you end up with some shoulder problems as well. So it's often something where we really do start at the neck and move into the shoulder when we're thinking about getting you in the right position. So this may be something, if any of you have seen physio, this is like our favorite exercise, but looking at trying to keep the chin sort of, I always call it, you're sort of giving yourself a double chin, but really trying to keep the head from trying to poke forward. So it's kind of hard to see when you're looking at me from straight on, but if you look at me from the side, this is kind of what I'm after. This is where I often have to find people. And so what that means is that neck position, when somebody tries to lift their hand, it's almost like it doesn't allow you to do it. So I often say if you can put your neck in the right position, your shoulder tends to come with it as well. We want to sort of see the shoulder blades, like I was saying before. This sort of shoulders in the ears problem is really important, or really big in all kinds of people with spinal cord injury. So just trying to keep the shoulder blades down and together. And if possible, and it's not always possible, trying to prevent the thorax or the upper back from rounding. Now, whether you do that with your own muscles, which people who have function through their thoracic spine are able to do, or you do that by having your wheelchair or other places that you sit to support you well. It just depends on your level of injury. And for people who are a little bit older, you know, time tends to, and gravity together are mean masters, and they tend to make us want to fall forward. So we often, when we're thinking about your posture, it's really trying to keep you in line. And then, of course, abdominal muscles are really quite helpful if you've got them. We really want you to use them. So this is somebody who's got more of a paraplegic injury or an incomplete injury. If you have abdominal muscles, trying to use them when you sit up is really quite helpful, again, to just kind of keep things in line. So again, I can't say enough how important neck muscles are. Our little wrestler, I forget his name, who has those big
Goldberg.
Those muscles on his neck there. That's what your trapezius muscle would look like if all you ever did was lift plates of weights, did shoulder shrugs all day. We actually, when we work with people, don't want you using that muscle. So that's your trapezius muscle, and as much as possible, we're trying not to use it. And the reason for that is this is the source of a lot of neck and shoulder pain. So this is when somebody comes up behind you and rubs your shoulders, the tops there, and you're just like, oh, I hate that feeling, or you've got a big knot there, or something like that. That's usually your trapezius muscle. What happens is when you have weakness, when you have pain, is that this muscle tries to do the whole job. And what we try and do is try to relax those muscles. And the way you do that is by using the muscles in between your shoulder blades and by getting your posture to be supportive of your thorax a little bit better, which is sometimes difficult, but it can be done to try and allow those muscles to relax. Now, I was talking about that chin tuck thing that I find to be so important. I just wanted to mention that the way that you do that exercise is actually kind of interesting. So in the picture on the right, where the little arrow is there, those are called your deep neck flexors. And those are muscles that are between your throat, so your esophagus and your trachea, in behind that, but in front of your spine bones. And they're really nice because you don't have to do very much work, and they don't take very much, sort of energy. But if you use them and get that chin tucked like that, that's a lot less energy using than our guy on the left here, who's trying to use all the big muscles on the outside. So it's almost like you got this secret little muscle in the front of your spine, where if you learn to do the chin tuck exercise, which is part of the exercise booklet, which I'll mention in a couple of minutes, you can kind of get to a secret path away from having to use those big muscles, which kind of make your neck feel really tight and really doesn't feel good in the long term. So I can't emphasize enough like how much, I think I've already said it 4 times. 4 times? Yeah, so neck posture. I thought this was a really interesting thing I found when I was sort of digging around the internet. What you see here on the left is somebody who has good posture. So you can kind of see that the ear is over the shoulder. And what that means is that the head is 12 pounds. So your head is really heavy, so it's 12 pounds. But as soon as you start to have that forward head posture, it's almost as if the amount of strain it puts on your neck starts double or triple. So with a little bit of forward head posture, that's 32 pounds of pressure or extra work that your neck needs to do to hold your head up. And with real forward head posture, it's 42 pounds. And then all of a sudden, those muscles in the back of your neck are having to do quite a lot of work. And they're so tight all the time that, in fact, that causes neck pain. Then your shoulder doesn't work properly. Then you cause shoulder pain. And it becomes this vicious cycle. So I think really thinking about where your head is in space actually becomes important to your shoulder pain. So this is what ideal sitting posture looks like. And I kind of laugh always because this is theoretical ideal sitting posture, and it's just not realistic for most people. Even in the able-bodied population, you can find all kinds of funny inequities and strange things about different people's bodies. And, you know, for example, I have a very slight scoliosis, so I don't sit quite straight, and then my back is tight, so I always want to sit backwards and do all kinds of funny things. So not only with the most brain power I ever use in a day do I ever look exactly like that. However, that is what we're trying to go for. Now, if you're somebody who doesn't have a lot of core musculature, sitting like that isn't realistic. So that's why it's a really good idea to work with a therapist to, you know, figure out what's the right mixture of straight up and perfect versus functional for you. I don't think about posture just in terms of your day when you're sitting up or standing or in your office chair or whatever it might be. I also think about it in bed. So an example of a place you can really help yourself is to make sure that you have a pillow that's the right size. I often recommend people use foam pillows. The reason I like them is that they're a little firmer and they give your neck a lot of good support. So if you look at the person on the left, you know, their kind of head is a little bit turned, and then the person with the pillow that's too small, the head's turned the other way. But with a pillow that's just right, a little bit like Goldilocks and Three Bears, you can see that that neck looks a lot more in neutral. And sleeping posture and the way you have yourself in sleeping is so important, because you might be spending 8 or more or less, depending on who you are, hours in bed. And that position, it can hold, you know, it's like the longest time you ever spend in one position. So if you've got it in a bad position, then you're really setting yourself up for trouble. The other thing you'll notice is for someone who's if you're a side sleeper, is that the person with the good pillow on the right hand side here, the shoulder doesn't have to squish forward. So this is kind of, it's kind of awkward to show you, but you know, when you're sleeping on no pillow or no pillow, it's almost like your shoulder is just sort of shoved forward. Again, you've just positioned the shoulder in a position that's not very healthy. One thing that we ask people to do, or we think is really good, is that just have a look at your posture. So if you can do it shirtless or in a tank top, taking a picture once a year just to see, are you starting to fall over to one side very slowly? Or are you noticing that your hips are doing something kind of funny? Look at your head position, look at your shoulder position. Are you hunching forward more? These things will kind of give you a cue that, oh man, maybe it's time that I kind of look at my position, whether it's in the car or in my wheelchair or in bed, to try and prevent the progression of that. And in some cases, but not for everyone, it is possible to kind of correct that. So aging. Aging can suck. It does lead to weaker muscles, which can lead to the things we've already talked about, poor transfers. Your muscles tend to be more susceptible to injury over time, and it can lead to poorer posture. The things you can do for yourself as you age is to take care of yourself. I said this before and I'll say it again. Eating well, which means making sure you get enough protein, but not too much. So the number of calories you burn is kind of interesting. For a younger quadriplegic, it's actually 1,200 calories or less in a day is what your body burns without having exercise put in there. But if you are older, as you age, the amount of energy your body uses actually decreases. So over time, the amount of calories your body actually needs and will actually use without you gaining weight actually decreases. So just really talk to a dietitian if you have access to that. If not, make sure that you're not eating too much, but I can't emphasize enough how protein is super, super important, because your body builds new tissues on protein and it replaces broken ones with protein. And if you're just eating, you know, pasta and a beer or something like that, you're not going to get enough protein to build up when you're injured. Stay strong. We talked about this as well. Doing exercise is really good. Don't stop doing the things you love. You know, if you're starting to notice that the sports you like to do are just a little too hard on your shoulders, I always say, you know, you don't necessarily have to stop doing them altogether, but maybe 3 times a week is too much. Those sorts of things. So staying active is really key. There are some guidelines out there from I think they're called the SCI Action Guidelines, which is how much exercise you should be getting through the week. I didn't include those in the resources Terry's going to send you, but I can send those along as well. easy to say and hard to do. Don't fall and don't get pressure sores. You know, as people age and the shoulders get a little bit weaker, or if they do weaken, it's a little easier to fall during your transfers, especially awkward ones like getting into the car, or if you're getting onto a couch or getting off of the couch is actually more common to fall. One of the things I notice is that can actually be the first sign that there's something going on at the shoulders. It's like, oh, I've always had a little bit of shoulder pain. And I know I'm getting weaker, but all of a sudden, oh, I had a fall. And then the next month, I was transferring a lot, and I must have been dragging my bum because I got a pressure sore. So that's often a sign that people are noticing, oh, you know what, I'm a little weaker because my transfers just aren't as good. So that can just be something to watch out for, but it's not necessarily a problem. Like your skin isn't always the source of the problem. There might be something else going on. So just to keep that in mind. And to consider changing your home or your wheelchair or anything else you're doing that might be putting stress on your shoulders to try and reduce the strain. Sorry. Excuse me. So I often say, as a therapist must, that therapists are good at their jobs, and it's a good idea to consult one before you buy any new equipment. And that can include wheelchairs, but I would also say that it includes things like office, if you get into an office chair for work, or if you're somebody who walks and you're looking at like a new set of canes, or the height of your walker, those sorts of things. I think it's a good idea to just have somebody have a quick eye on it. So that you're not causing yourself more damage than you actually need to. We at GF Strong do seating assessments, which is a pretty common thing through all therapists across different diagnoses and that sort of thing. And what we do is just look, has your range of motion changed? Do you need a little bit of correction because your pelvis has started to do something a bit funny? How do we sit you in such a way that it doesn't cause your spasticity to be worse? Those sorts of things. I think I sort of touched on this, but posture is important, but not if it causes you to not be able to function. So if you get into a wheelchair and immediately the first thing that happens is you fall forward because it's too upright, then that's a good idea in theory, but it's not good in practice. So we want you to be comfortable. We want you to be able to get through your day and be able to function doing all the things that you love to do. And we want you to be safe. So a good example of this is that sometimes people want to have a super upright wheelchair and be as aggressive with their wheeling as possible, but all of a sudden what that means when you're feeling sore and you're always kind of leaning back to stretch is that actually you might be more prone to tipping backwards. And if you have anti-tippers, that's a good time to use them until you can get your chair adjusted. Making sure your brakes work. As you get to if you're having more trouble with your transfers, what you'll find is your brakes become more important. So when you're young, you might not use your brakes very much at all, but as you are getting a little bit weaker, you might notice that you're kind of pulling on the chair or pushing on the chair more than you used to. So that becomes more important to get your brakes make sure your brakes are working. And brakes only work if your tires are pumped up. So if your tires are really, really flat, then your chair might try and escape on you. And obviously that's a good place to have a fall. The other thing is for wheeling is that dog hair, dryer lint, what else have I found in there? Wrappers. I found a candy wrapper in somebody's castor housing once. That was an interesting one. Just making sure that all the parts of the chair are not gummed up with just the usual stuff. And that can be, whether that's for you, if you are someone who has a vendor who can help you with that, or if you want to learn to do it yourself. It's not rocket science, it can be done, but you just need to make sure that you learn how to do it and you do it regularly. Some of the things in wheelchairs that tend to be a little harder on your shoulders are things like having a folding chair. It's a little more convenient, I know, but it tends to be less efficient when you're wheeling. And it can also be a little harder to transfer off of in some cases, but not all cases. Tubeless tires, I pretty much tell everyone to stay away from. So those are those run flat tires that are just solid plastic. Not a lot of people use them, but occasionally I do see them, and they're just not very efficient and they're not great for transferring either. And heavy chairs. And by heavy chairs, I don't just mean the chair itself, it's all the things you put on the chair. So that can be the grocery bags you're putting on and those sorts of things. And so those are the things you want to think about. Every little thing that you put on your chair, not great for wheeling, but also not great because you're having to pull it off every time. And this is a big reason if you're getting in and out of a car or whatever it might be, pulling things off, having to reach under things to grab stuff. Those are things that every day, it's a little bit like sandpaper. Every time you're doing it, it just sandpapers your shoulders just a little bit more. So just trying to reduce the everyday things that you're doing that might cause damage overall. One time doesn't cause damage, but 1,000 times, 2,000 times might be causing you some damage. So there's lots of things to be said about wheeling, but the 3 things that I'll say today is that you need to take fewer, smoother strokes. And by that I mean, don't do lots of little pushes. Try and do long, smooth pushes and make sure that your hands aren't hitting the wheels too hard or the push rims too hard. Take breaks when you can. It's muscles are something they need to get oxygen. And if you're pushing really, really, really hard all the time to go up a hill or whatever it might be, in a muscle that's, if it's feeling sore, the more you can give it breaks to let the oxygen back in, the better off you'll be. And try to do less rough terrain and also, of course, less hills would be ideal. Now, obviously, those are things that are easy to say and hard to do. And I understand that. I would just say that think of it as sandpaper. The more sandpaper you're doing, the more damage it is long term. But try not to, there's always a balance between, I want you to keep doing the things that you love, as long as you don't feel that they're kind of damaging your shoulder too much. So on average, people do 15 to 20 transfers a day. Every transfer is a piece of, I don't know, the sandpaper analogy is maybe not working for me, but it's the rough sandpaper. Transfers are definitely one of the worst things for your shoulder. Like I said, try not to fall. And the other thing is try not to drag your bum, because that's how you get pressure sores. There's lots of things I could say about how to make your transfers better. And this goes for people who are in power chairs as well. You know, really trying to make sure your chair is as close to the surface as possible. Making sure if you are in a manual chair to not let your bum land on the wheel or have to go over the wheel. So bring your bum forward in the chair before you transfer is really important. And another point I'll just make is that as you age and if you are feeling less strong, I think it's important to think about using physics in your favor. And the way I tell people that is that, like I said earlier, your head is a big weight. And if you try and push up straight up and down like this, that's a lot of work for your arms. But if you come forward and you get your head sort of off your bum, for lack of a better term, if you move it forward and use it as a counterweight, all of a sudden your bum becomes easier to move. So some of you have probably heard people say that, and I think that it's true that those things are easy to say, but if you can kind of think about the most you can bring your head forward without feeling like you're going to fall, obviously, the less actual effort goes through your arms and shoulders, and the better off you'll be. The other thing that some people don't realize is that even for complete paraplegics, they will have done some research, and they've shown that 30 to 40% of your body weight actually goes through your feet, even if you don't have function in your feet. So the feet should be used as a point of stability, and that means that they should be placed on a stable surface. Now, we would love for them to be on the floor. That's not always possible, and we get that. But just be aware that your feet are an important part of the picture. I was just at a conference recently, and they had this really great resource, which Terry's going to send you. This is an online transfer training program. It's just 1 hour, and it goes through a few ways to make your transfers better. I talked about 2 little points. This goes through it in much more detail. And they actually did a little bit of research recently, and they showed that people were able to improve their transfers with this just as well as having somebody instruct them in person, which I, as a therapist, was very impressed by. So yeah, this is like brand new. They're just doing research on it right now. So if you have an hour to spare, the University of Pittsburgh has done a lot of work on helping people improve transfers, and I've been really impressed by a lot of their resources. The last 2 slides you just saw are from them. So changing your home. these are kind of things that, once again, if we can reduce the little stresses each day, that will in the long term help you. So overhead reaching. The reason we think a lot about overhead reaching for shoulder pain is that as soon as your shoulder goes above about 90 degrees, all of a sudden your rotator cuff is actually having to do the work of big muscles, even though they're small muscles. So if I'm reaching for something here, I don't have any big muscles like my chest muscle, my lat muscle that's in the back here. Those muscles can't help me anymore. So if you're overhead reaching a lot, that is a lot of strain on your shoulder, on your rotator cuff muscles, and on the ligaments and so forth as well. Uneven transfers. So if you're somebody who's transferring, you may, and you're getting into the bathtub, the bottom of the bathtub, for example, or you do a lot of floor transfers, that's a lot of pressure on your shoulders. So consider if it's possible to either break up those uneven transfers or reduce them. Dangerous or awkward transfers. Who did I see recently that they were trying to do their toilet transfer from facing the toilet? And that's really hard to do without being like throw yourself around or do those things. So anything that's requiring like ballistic motion or anything that's requiring more force than is absolutely necessary, see if you can change. And also reducing heavy lifting. And this goes for everybody from people who are walking around to people who are, in power chairs. One thing I often work with people, is there a way to not have to reach behind you for your grocery bags? Because reaching for a grocery bag all the way around or backwards like this is a huge stress on your shoulders. I'm not sure if you can see, but imagine I'm reaching for my my cane and I've got some milk or something on there. Like that is a big stress on the shoulder. So one client recently, we just worked on a little pivot system to try and reduce the amount she had to actually lift. And she just kind of actually built herself a little thing so that it swung from the back of her power chair to the front. So that she wasn't reaching behind as much to lift things off. So those are all the little things that you can do. And for her, she actually said, she's like, that's the number one thing that I changed that really made a difference for me. It was the groceries on the back of the chair that for her was the big thing. So unfortunately, you power chair users don't get off the hook quite so easily either. So in terms of stretching and strengthening, as I said, I'm a physio, so I have to say these things. Terry's going to send you a link to a booklet that the therapists here at GF Strong came up with, and it's going to go through some of the information that I talked about today. And it's basically 4 stretches and 4 strengthening exercises, which you can use at home with a TheraBand, which you can get at pretty much any exercise store for like less than $10. And what's great about it is that it's pretty quick. It goes through that chin tuck exercise I talked about, 4 stretches for the shoulder, 4 strengthening exercises for the shoulder. And those are the ones that from the research that they've done have been really successful at helping people to improve their ability to put the shoulder blade in the right place and reduce their pain. I thought about going through each one by one today, but I didn't want to bore you to tears, so I'm not going to do that. But that is really available online. And it can be something that if you are, like Lisa was saying, going to see a therapist who maybe isn't as familiar with spinal cord injury, because I know if you're not living in a city, that can be hard to find somebody who really understands that. Taking that with you and just being like, hey, could you run through these with me, can be really successful as well. I've done that with quite a few people where I'll either send it directly to them or to their therapist. And I just say, hey, this is something that we run through. And any physio will be able to go through that with you. And it's pretty straightforward. If you've had therapy before, it's something that you could start with yourself. And if you're having any trouble, to talk with your therapist. Another resource that I'll point you towards is an app that is for both Android and Apple products called SCIX. It's from the Shepherd Rehab Center in the US. It's really great because it goes through exercises for everyone from complete quadriplegics who have no arm function and need help to do their exercise program, all the way down to somebody who is a para. So it's only upper body, but it does have videos to go through every exercise. I like it because if you're like me and you get bored when you go and do an exercise program again and again and again and again, and you're just looking for something a little bit different, they have a few exercises like boxing with weights or different ways to do pulley exercises and stuff that you might not have seen before. Excuse me. So it's just a good way to kind of prevent gym boredom or exercise program boredom. And only some of them need a gym. So if you don't have access to an accessible gym, there are some on there that don't need that. Excuse me, I'm just going to stop and take a break. Terry, do you want to just see if anybody maybe wants to put their hand up?
You can unmute yourself, Jeff, I think.
I wrote a whole bunch of stuff down.
Oh, good.
Okay.
Yeah, so maybe I can run through it.
Sure.
Using a transfer pole, is that bad?
Not necessarily, as long as you're able to use it in the right way. So sometimes what I'll do with people who have stuff like that, whether it's a grab bar or a transfer pole, I'll just make sure you're not putting your shoulder in a really awkward position. So I would say that that's something that if you have an occupational therapist or a physiotherapist to look at with you, it's not necessarily bad. I would say that nothing is necessarily bad. It's just, how are you doing it well, and is there a way to do it that puts less stress on the shoulder? Good question.
The other thing, I've never had a seating assessment.
Okay. So do you have someone who works with you to get your equipment done?
I have an OT, but
Yeah.
I haven't had a real, like, an in-depth one.
Okay, so that's something you can talk about with them. You can also get a referral to, I'm not sure where you live, but if
I'm
you're,
in Kelowna.
you are, okay. Yeah, I mean, that is something we do here at GF Strong. It is something that they can do. It's not necessary that you actually come here. I don't want to say that we're the only people who can do this. Certainly we have more expertise with SEI, and we try and support clinicians in the community who are in your area to try and help you. But yeah, there are resources available online about how to do a seating assessment, or if your clinician wants to pop us an email or give us a call about how to do that, we're certainly happy to provide them with support. Just because we know that it's quite onerous to try and make it down to Vancouver. So
yeah, it is for me.
Yeah, exactly. So we try and support your team as much as we can, to try and make sure that, you know, they understand what we look for in terms of your range of motion, your flexibility, what things could be corrected, those sorts of things that we look at in a seating assessment. And you know what, it's funny, I had somebody say that to me recently, and they said, I've never had one of these done. And it was funny because I talked to their OT, and they said, oh, we just did it in pieces. So it may be that somebody is doing this, but you just don't even notice because it's just part of the whole process. So they may have already been doing pieces of it. I can't speak to that. So, you know, the process that we have here is just very SCI specific, and it's in way, but there's many ways to sort of skin that cat.
I've tried every sport and had to retire from all of them. Now I'm doing yoga, sitting yoga, like chair yoga.
Yeah,
is that
great.
something that's good?
Yeah, absolutely.
Okay.
I love yoga for many reasons. I mean, what we know is that yoga has amazing effects in terms of flexibility, but also in terms of sort of in your brain. It's very similar to meditation and mindfulness, which maybe is a topic for another day, but in terms of trying to get to a place where you can move in a healthy way. Because what happens when we're in pain is that we start to think that every little movement is going to cause us pain, and then we don't want to move, and then we can't move, and then we get stuck. And then, so I would say that I have used yoga with many of my clients and really recommend it to them as a way to move in a way that is good for your brain, but also good for your body.
Yeah, we do have actually we did a mindfulness one. One of the first ones we did was on mindfulness, actually. So
Awesome.
there should be the YouTube video. If anyone's interested in getting that link, you can just email me and I can send it over to you. I do have a question, actually, Tova. So sort of a little bit from what Jeff was saying, transfer boards, and you know how they have the medical beds with the arms and stuff, and people use them to roll over. How good or not good is that?
So yeah, transfer boards, I can't believe I didn't have them there. Transfer boards are great. I would say that there are the odd person where transfer boards just seem to cause more trouble than they solve, because you've been transferring one way for so long that trying to introduce something new seems to cause a little bit of trouble. Transfer boards are great because you can split your transfer up into different parts as opposed to trying to do the whole thing in one. So I often will say, you know, maybe you're not using the transfer board for every transfer, but you are using it when you're sore, or if you have to do a transfer that's a bit awkward, or the space between your surface and your chair is wider and you just don't fall into the hole in between. So yeah, I would definitely recommend, you know, it's sort of one of those cheap and cheerful ways to kind of reduce the strain on your shoulders. And in terms of using like bed rails to help you turn at night, I mean, for a lot of people, you need to use them anyway, right? You need to have something like that. I would say that the best thing you can do for yourself is that when you're thinking about trying to get yourself to use some momentum is a really good idea. So, you know, we kind of tell people to kind of throw themselves around, which sounds like a bad thing. But what that means is that maybe you don't have to pull as much on the armrest as you do at other times. But honestly, you know, that's really individual, and it really depends on whether you're able to do the kind of momentum technique, but really trying to, as much as possible, use whatever tools you have. So if you have a bit of leg function, can you know, make sure to throw your leg across before you try and throw your upper body across, because that's kind of an easy way to do that. If you are someone who is a little wider in the hips, just being really realizing that trying to do a turn from one side to the other, you might want to just split that up into pieces if you can. So just, yeah, that's not a sort of a non-answer, but
Yeah,
it's
no.
really it's really individual to you.
Mm-hmm. Patty just emailed me here, so I'm just going to try unmuting her and hopefully we can hear her. So, Patty?
Hello, can you hear me?
We can.
Patty.
Hi, Tova.
Hey.
Hi, everyone. I just wanted to thank Spinal Injury for doing this on shoulders. I've been injured almost 40 years, and this wasn't really addressed when I was in rehab. And I think if you guys have it on, if you have it on video, or we can re-look at it just for a brush up, it would really be really good. And for the fellow in Kelowna, I hadn't been to a physiatrist or GS Strong for 37 years, and I just came back from there, and it was excellent. And I just suggest that you take all the suggestions that Tova suggested, and maybe you know, like I've had a lot of, obviously I'm older, and I've had a lot of muscle tears because as we get older, we I guess aren't as strong, and we are more susceptible to damage, and I'm an example of that. And so I'm having to relearn how to transfer and stuff like that. And so I just want to say thank you for Encore Injury BC for doing this. And I don't know if, Terry, is this going to be available on video for us to relook at?
It will be, yeah. So I am recording it, and we'll share the link with you guys once it up. It does take a little bit to get it up there, but I'll do my best.
Yeah, and then my suggestion to the fellow in Kelowna is just maybe if you're not being addressed in your area, maybe do what I did, because I wasn't being addressed in my area, and I just made an appointment and went to GS Strong. So that's my approach to that, and it's well worth it, I think.
Yeah, I mean, absolutely. We are provincial service, which means that we can take referrals from all over the province. And the website for GS Strong has an outpatient referral form. And what happens is our intake coordinator will just call you and say, are you not able to be managed in your own community? And then if you're really are not being able to, if things are just not working up there, then we can see you. I would say our wait list is a little bit long right now. So just if you're thinking about it, good to put it in earlier rather than later. The other thing I'll say to what Patty said, I think it's really interesting. It's one of those problems, it's kind of almost like shoulder pain is one of those weird problems where they didn't used to have so much of it because I don't think people were living as long. So people are living much, much longer with their spinal cord injuries now, and we're starting to see a sort of double effect of everybody ages, but I think when you age with a disability, there's sort of this sort of almost like a multiplication effect where little changes have big effects on your life. So it's sort of good news, bad news is that people are able to, they're able to live a lot longer than they could 10, 15, 20 years ago, which I think is great, but it does come with its own set of challenges. Okay, going on here. So in terms of stretching and strengthening, I recommend people do this 3 to 4 days a week to start. One of the interesting things is that they did this research, not that I think in SCI, but just in general strengthening a few years ago. And what was really interesting is that you actually get 30 to 40% stronger, and you haven't changed the size of your muscle at all. So actually what you're doing is you're just training your brain to do a better job of using your muscle. Now, do I think it's a good idea to continue to strengthen? And you really do need to keep up this 3 to 4 days a week if you're trying to get muscle growth, which again is protein, so keep eating your protein. So 3 to 4 days a week is if you're really trying to strengthen. If you get to a point where you're like, you know what, I feel pretty good, you can go down, and it's just once in a while, you just need to do it to remind yourself. So then it's just like, oh yeah, that's really how I should be moving my shoulder. So that's kind of one of those things where it doesn't have to be every day forever, but when you're trying to change your brain to make it use your muscles better, and when you're trying to grow your muscle, you really do need to do it every other day. For the stretches, we tell people to hold them for at least 30 seconds, and if you can't at first, you can work up to that. And for strengthening, 10 repetitions, working up to 3 sets. Now, if you start to do an exercise and it's causing you more pain, that's not good. Go on to the next exercise, stop and take a break, and kind of reapproach it and see how it's going. And that can just be a sign that you maybe need to talk to a therapist about how you're doing the exercise, because it can just be a simple change like, oh, just kind of tuck your elbow in, and that will make it better. So it's kind of hard to teach exercises over the internet. Try them, the ones that are in the booklet that Terry will send you the link to. But there's still a role for having somebody kind of teach you the little bits and pieces that make these go well.
Tova, I just had a question come up from Lisa here, so I'm just gonna let her ask if that's okay.
Absolutely.
Lisa, go ahead.
Hi there again. I am wondering, like, if at some point you can go over the best way to choose a therapist, because I've gone to different physiotherapists in the community and I've found that they didn't really understand what I do, like what a wheelchair is necessarily about, and then they just have like strange expectations, or they don't get it. I don't know how to explain it, but it doesn't work. So.
Yeah, so that's a hard question, and I would say that it's not one that I have a great all-in answer to. I do somebody who has experience working in with other disabilities is a really good idea if you can't find someone who has spinal cord injury expertise, of course. So I would say that the first step is to talk to other people who have spinal cord injuries that have seen other therapists, and just seeing if that they have someone they can recommend. I would say word of mouth is that's how I find my physio, so that's a good way for you to find your physio. If you aren't able to find someone through word of mouth, I would just say that looking for somebody who has experience working in hospitals of any description, if you can find someone who's worked in a hospital, like a rehab hospital, that's great too, because I find having an understanding of disability in general is really helpful to understanding the weird picadillos of having a spinal cord injury. Certainly not every disease is the same, but it does sort of go a long way to helping them understand what does it really mean to be in a wheelchair all the time and those sorts of things. In terms of skills to look for, I would say that, it's not necessarily one particular skill, like you have to have manual therapy or acupuncture or whatever it might be, but I would say somebody who has lots of experience. I tend to say that, you really want to look for somebody who has a wide breadth of experience is a really good idea. And somebody, like I said, who just maybe has some experience with neurophysio is better than somebody who's only orthopedics. That being said, there are some really great orthopedic therapists out there. So that's my non-answer to your question.
I also would like to plug here our info line. Heather's actually online right now.
Yeah.
The SCIBC info line, and they are a wealth of information. Her in particular that can direct you to anything. So that's a good one.
Great.
Yeah.
Yeah, that's a really good idea, because they'll know people who maybe have a bit more experience. And I'm always surprised. There's some like really talented neurotherapists who live in these. Where's the last one? So one of the people who teaches us physio is she teaches these like weekend courses that we all do, and she lives in Bowser, which is like a very small town on the island. So I was like, oh, that's the best, must be the best sort of small town in the whole wide world. She's quite terrific. Anyway, I just thought that was quite funny. So in any case.
Okay.
So the last section I have today is to go over imaging, injections, and surgery. So I'm not a doctor. I did have one of our physical medicine doctors review this with me just to make sure I wasn't saying anything that was going to take you in the wrong direction. But to give you a general idea, this is something that I always tell people, and I kind of touched on this earlier. Imaging and pain are not always related. So you might have somebody who has a ton of pain and their imaging actually doesn't look that bad. And you have somebody who has lots of things on their imaging. They got a rotator cuff tear, their biceps tendons torn, and that sort of thing. And they're like, you know what, I kind of feel okay. So I often say that it's more important to listen to your body than it is to listen to a test that somebody gives you. The exception to this is an X-ray that tells you your bones are broken. If your bones are broken, you got to listen to that. So the types of imaging that you might have heard of or that you might be interested to know about are the X-ray, like I talked about. You would look for broken bones from falls or that sort of thing. This can also be a way to check for arthritis. A CT scan is less common in shoulder pain, but it does sometimes happen, and you'd be looking for broken bones. That an X-ray is just one plane, whereas a CT scan goes through the bones. If you haven't seen a CT scan, it's like a series of X-rays through the body, so it can catch things that an X-ray might miss. Bone scans are often used to look for stress fractures. So stress fractures can happen where you have these sort of very small fractures that are actually not from one bone, like one incident where you fell, but maybe it was just over time the bone broke, which can happen. I would say it's less common at the shoulder than it is in other places, but it does happen. And it also checks for inflammation. So a bone scan is looking at how are the cells pulling in more stuff from your blood to try and heal, and so that it checks to see where those sites of inflammation are. The two that are the most common for shoulder pain, I would say, are the ultrasound and the MRI. So both of these look at soft tissues. Ultrasounds are often not very helpful in people who are very overweight, because it has trouble looking through fat tissue. But it's pretty good, and I like it because it's relatively fast. So the problem with an MRI, well, it seems like a great idea because it's the most sort of definitive in assessment. They take a long time to get. So any of you who've had to wait on a list for an MRI know about this. This can be many months waiting. So I often say try for an ultrasound first and see what it finds out, and then that may sort of direct you in which way you need to go if it's something that isn't being helped by all the other things that we talked about today. Excuse me. So injections. So some of you might have heard of people, it's like, oh, I got some stuff injected into my shoulder and it really helped. So the most common injection that you're going to hear about is a steroid, most often cortisone. This reduces inflammation in the joint. I would say that my experience with this is that the results tend to vary. Now, it varies based on the experience of the person doing the injecting, how accurate they can be based on what imaging they have, and that it does have some side effects. So that's another thing you need to consider. So you want to talk to your doctor about it because it does come with some risks. One that I actually hadn't heard of and Dr. Wilms was telling me about is something called barbotage, which is removal of calcifications. So there's a specific type of disease called calcific tendinitis. So this is actually where the tendon or the muscle turns into calcifies or almost turns into bone. And they can go in and they can actually use a needle to extract that. So that's not necessarily an injection, but I guess you're using a needle to pull something out. Two more that are less common in spinal cord injury, but you hear about. So this is hyaluronic acid is, some people call it joint fluid. So it's actually an injection of a fluid that's a little bit like the joint fluid that's already in your shoulder. It's not proven in spinal cord injury and only moderately proven in healthy people. So this is really something you would want to sort of approach with some caution, just because there isn't great research to support it. The same would go for something called platelet-rich plasma, or PRP, and stem cells. Again, these are things that are kind of becoming sexy that, you know, you can pay lots of money for, but there's no evidence to support that they actually work. So that would be something you'd be paying for privately, both the hyaluronic acid and the last two as well. And I just really approach those with caution, just because there isn't a lot of research to support their effectiveness. So just a few notes on surgery. So I'm not going to talk about types of surgery you can get, just because that's really a discussion you would have with your doctor. But I wanted you to consider a few things about surgery and having surgery. So our kind of party line here is that surgery for your shoulder should be a last resort. For the most part, what they're trying to do is reduce your pain, but they're not trying to improve your power. So if you're going into it thinking, hey, this is going to make me able to transfer in the way I used to, the likelihood is, and the research shows, that people come out of it actually with less function than they had before the injury. So I would just say to really be cautious about what you think you're going to get out of this. What they had before the surgery, surgical repairs can fail. So there are people who have surgeries and then all of a sudden that tissue that's been sewn together comes apart or whatever it might be. And like I said, people report less function and less range of motion in some cases as well. So we would prefer you to change your environment. Sorry, I had my slides a little mixed up there, but we prefer you to change your environment, your wheelchair, and your behavior before you consider doing surgery, just because it can actually mean an actual decline in function. Now, in some cases you need surgery, or you've tried everything else and you really do in the end need to look at the surgical option. Some things to consider is that this is a big deal. You will not be able to transfer independently for 8 or more weeks after surgery. You might not be able to wheel. Your range of motion is likely to be restricted, and you're likely going to need more help at home. So this might mean you need help transferring. It might mean you need help to do cooking or cleaning or any of those things that you can do. Maybe they're painful now, but you can kind of still do them. More than likely after the surgery, to let things heal really well, the doctor will have you on a really, really restricted program. Some people aren't able to actually go home. So some people are needing to go into assisted living, or they're needing to have more home care in before they can actually get back to their previous level of function, if indeed they do. So that's my scare tactics around surgery, is just to really consider what you're getting into, because most people come out of it and kind of say, you know, if I probably could have waited, or I could have tried, you know, changing to a power chair, which is something that some people decide to do from a manual chair, or if I'm a part-time walker, maybe I could have looked at trying to use my wheelchair a bit more, or reducing the number of transfers, those sorts of things, to try and stave off surgery. Now, a lot of the times you don't necessarily need to rush into it. It doesn't have to be today. You can wait and try these things, and then reapproach surgery at a different time. So I think that's all I had. If we just want to go through any questions that people have about that last part, or any questions you might have at all, I'm certainly happy to answer those.
I'm going to add another plug for Neil Squire right now. who has a program called Technology at Work. And if you need any sort of like equipment, so when Tova's saying like power chairs or smart drives or anything that will assist you in order to do any volunteer work or paid employment work, they have a government funded program, but it's only available until March. So I would get on that right now. If that's something, if your shoulders are an issue for you, that might be something that you can look into. And on that, let's start. Teresa, any questions or comments?
Yeah, I was wondering about the yoga, although Tova suggested doing yoga. What kind of quads? Also, like I've had a couple of injuries to my back.
Okay.
So my center of gravity is even worse than just the quad.
Yeah.
So I'm just wondering where can I look at, or where can I?
Yeah, so I'm not sure. So one of the things there's actually more and more I'm finding adaptive yoga classes are popping up, not just in Vancouver, but all over. Parks and recreation boards, if you don't have one in your town or your city, parks and recreation boards often have a mandate to support people with disabilities. So there may be a yoga teacher who has an interest in that sort of thing, and you could ask the Parks and Rec board to see if there's someone available to start teaching that. We've been really surprised, like the Surrey Parks and Rec board has just been like super into helping getting equipment into community centers recently. And they're also doing a seated exercise class, and that was totally driven by someone in the community who just really felt that was something that they wanted to get started. So I was really impressed by that, and I would say that most of the publicly supported Parks and Rec boards have a mandate to really support people with disabilities. So if it isn't available, talking to someone there about getting something started can be a way to do it. It's sort of hard to do by yourself. If you are someone like yourself who's a quad who needs maybe a little more direction and a little more support to try it. I can't think off of the top of my head of a good resource for it, but I would say that I love yoga teachers for being, they're very adventurous and trying things and that sort of thing. You just have to tell them, can't touch here, don't do that, those sorts of things. And there are people who have expertise in adaptive yoga all over the province.
Teresa, also one of our peers, Mary Jo Federley, she's C5 quad. She does adaptive yoga. She's a teacher. She's here in Vancouver, but she might be a good connection for you, just to see if there's anybody in your area or that she knows. Oftentimes she will go to a community center and teach other teachers how to do it. So.
Yeah, but it's really is for all kinds of levels, and I really encourage people to try it just because it's a great combination of breathing work, stretching, and safe movement that doesn't cause more damage.
Mm-hmm. Mary Jo's also done some videos too that are online too.
Oh yeah, that's right. I forgot about that.
Yeah, on YouTube or?
Yeah, on YouTube. Yeah.
Okay.
Yeah, maybe we can include that as well in our package of stuff we're sending you.
Maureen.
Yes, I do have a question. I do weights. I'm a paraplegic, and I do weights every day and stretches, but I do it every day. Should I only do it every second day?
No, that's just kind of the minimum that I tell people. I think there's nothing wrong with doing the weights. I would say that it depends on what you're trying to achieve. If you're trying to make yourself stronger, you might go down to every other day and try heavier weights. Now, of course, you don't want to choose something so heavy you're going to hurt yourself. So there's always a bit of a balancing act there. My experience has been generally people are not choosing weights that challenge their muscles. So you are doing the thing where you're making your brain stronger, but if you're trying to make your muscle stronger, you really do have to choose a weight that's actually going to challenge the muscle. Of course, the problem with that is that sometimes that makes you tired for the rest of your day. So it's a bit of a, it's always a bit of a balancing act. So it depends on what you're trying to achieve. I think for trying to maintain the status quo, every day with a sort of moderate weight is perfectly fine.
Okay, next we have Jeff.
Few more questions. I did the Neil Squire program through Kelowna and for computer comfort. Great programs, just kind of to let people know. The other thing, my core, I have to actually lock my ribs, and I'm finding that they're popping out.
Right.
Is that common?
That is a hard question to answer at distance.
Yeah.
I would say that it's a good idea to talk to a therapist about that, because I don't know if I
Okay.
can answer your question without getting a set of eyes and hands on you.
Okay. A memory foam pillow. I have a side sleeper.
That's great. If you can use a memory foam pillow, it's IKEA has them for like $12 or $15.
Yeah, Costco's good too.
Yeah, no, it's good. It really can make a difference. So, because what you may not realize if you're using a pillow that's too flat, even if it is a memory foam pillow and it's not big enough for you. So like I'm a tall but not very broad-shouldered person, but I had a gentleman and he was quite broad-shouldered, and he was like, I'm using a memory foam pillow, and I sort of looked at him and he sort of is still like this, right? So you got to consider yourself when you're making those sorts of choices. So for him, it was just, we just needed to bump it up a little bit, and that was made all the difference to letting him sleep through the night.
I use the bed rail on my bed to roll over at night. Now I'm half asleep. So is that a bad thing to be doing?
I would say that it's bad if it's causing you pain.
It is.
Okay. So, those sorts of cases are things where it's, talking with your OT and trying to problem solve is a really great way to see, is it something like, could you attach a loop so that you're not having to reach up as high? Is it that you could, what you actually need to do is, I don't know how adjustable your bed is, but is it possible to, if you sat up a little bit, to do it instead of, I'm not sure if your bed has adjustability, but these are just things we've tried with people where you can actually bring the head of the bed up, and they just find that actually for them makes all the difference, because somehow being totally flat when they're trying to turn just doesn't work for them. Some other things that I've tried with people are things like making sure that when you're pulling yourself around, that your hand position, while it seems like a good idea to reach as far away as you can possibly reach, actually this is a harder position on your shoulder. So could you just look for a different place to grab? So again, these are the sorts of things. It's I would say that the sort of little nitpicky things to problem solve around reducing the amount of stress you're putting on when you're doing things like turning, I would say that that's something you and your OT could discuss.
And two other points. I am overweight, and I just don't know how to get the pounds off.
So losing weight is hard. Losing weight is hard for everybody, not just people with spinal cord injuries. The sort of short answer is that it's 80% diet or more. As much as I think exercise is really important, and I'm not saying don't exercise, I think you absolutely should. It is the diet more than anything that really determines whether you're able to lose weight. And so that can be a case where, like I said, you don't really realize how little 1,200 calories, or I'm not sure about your situation, but like, it's not a lot of calories. It's like, a Big Mac puts you over the top pretty quickly. Do you know what I mean? So it's just, these are not easy asks. And I would say that of all of the changes that people say to people of any description, just say, oh, you need to lose some weight. That's probably the hardest one. So I try to say to people, even if you can't lose a lot of weight, being healthy by still reducing your calories just a little bit, maintaining your protein, and trying to exercise, what we notice is this is less of a shoulder thing and more of an overall thing. It's really interesting to watch that even by making those small changes, even without losing any weight, you notice that people's heart disease and issues around their general health seem to improve, even if the actual weight isn't falling off. So I still encourage people to eat really well, because that, is often a much bigger thing than any physio that I can do.
And then the other thing, I just went 6 months ago and bought myself a power chair to do errands. And I'm still in a lot of pain. It's been 16 and a half years. I'm a para. Yeah.
Yeah. So, you know, you're dealing with some of the issues that we talked about today of just like all these things coming together at once. And you know, I think really just, you know, what are the small changes? I think moving to a power chair is just one of them, but I would suggest that for most paras, it's not just wheeling, it's really transfers that really can really wreck you. And so, not saying don't transfer, I'm just saying, you know, what are the transfers that you could change to make them a little easier on you? Those are the types of things that I really think about. And, you know, it sounds like for you, you know, you're using a pole and doing some of those different things. Is there something that you could problem solve with your OT around, you know, using something like a sliding board, or just reducing the number of transfers you have to do in a day? So one example is that I had somebody switch from getting into separately onto the toilet and the bath bench, is that they just were able to set up their bathroom in the sense that it was like one transfer from the chair onto the toilet seat, and then they scooted over across to the bathtub. So that was just one less transfer in the day, or two less, I guess. So is it more than that? It might be 4 less. I can't decide. But it's just reducing the number of transfers you're having to do. So it's really chipping away and just being really truthful with yourself. What changes am I willing to make to try and reduce my pain? And really understanding that there may be cases where you can make all of these changes and do all of these things, and you may still have some shoulder pain, and really looking at understanding chronic pain as a general topic and how to manage that really well is it's a whole other can of worms that I don't have time to go into.
Thank you, Spinal Cord Injury BC, and thank you, Tova. I don't know how to say it.
Yeah, you said it right. Tova.
Yeah, Tova, yeah. And yeah, I'll keep chipping away, as you said. Thank you.
Good.
Awesome. Thanks, Jeff. Howard, do you have any comments or anything?
I do have, like I have arthritis in my shoulders and AC joints. And I know don't overdo it, don't underdo it story, but do you have any advice for arthritis for shoulders?
Yeah, there's no easy answer to that one. You know, arthritis is really the wearing down of the joint. So what we know for, especially for something like you said the AC joint, which is the one, I don't have a picture in front of me, but on top there, you know, that's a tough one. It does cause a lot of discomfort. It's a tiny, tiny little joint all by itself, and it seems to cause more discomfort for lots of people than I would have anticipated. The easy answer to that, I don't have a perfect answer. I think really putting your shoulder blade in the right position is the most important thing you can do for all of those arthritis things. Because what happens for AC joint in particular, when your shoulder blades start to ride up your back, or you're sort of tipped forward, so people who are kind of hunched in that sort of thing, grind. And that is literally like sandpaper. Those are two joint ends of your bones that are worn down and they're rubbing against each other, and it's just so painful. You know, in terms of medical management, you can talk to your doctor and looking at things like injections and those sorts of things. But as I said, it has really variable results.
And supplements and whatnot, that's a whole other story, I guess.
Yeah, so there's been a lot of great research around what supplements are effective. There has been some looks at glucosamine as a herbal supplement to try and maintain your joints. There's no randomized control trial that would say that it's going to change your life. As a not going to hurt you, probably maybe might help on the off chance. Could you do it? Sure. I think more than anything, like I say, I've always been surprised how important making sure you have protein is for lots of reasons. I would also say that there has been some research done by the folks at ICORD, which is the research center here in Vancouver, on something called the ketogenic diet, which is reduces the number of inflammation-causing things in your diet, and really is focused on some parts of it. But I'm not an expert on it, so I'm not going to go into it.
Okay, that's an idea. Thank you.
Mhm.
Awesome. Thanks, Howard. Next we have Helmut. Helmut, do you have anything?
Well, sessions, a lot of information. One, and I have, and you may not have much information on it, is there is this technique now, surgery, the reverse shoulder replacement. Have you got information on that?
I know about it. I've seen two patients. One was not a spinal cord injury patient. I saw a gentleman with incomplete spinal cord injury who's somebody who's a walking client who had it done when he fell and broke his shoulder. My experience has been that it's more successful than a classic shoulder replacement. So what we're talking about is just, you probably heard of a joint replacement, right? So they're replacing the ball and socket. So if we look, maybe I can go back because it's really hard to explain without a picture. So basically what they do is they actually replace, so just looking down here, they actually make the humerus, the arm bone has a socket. They like shave it down, put a piece of metal in there, and then they put a ball on your shoulder blade. So it's a relatively new, they've been doing it for quite a while actually, but I think that it's becoming more common. And the idea is that it's more successful at getting range of motion. So the one gentleman with spinal cord injury, again, an incomplete, who has quite a bit of upper limb function, he had it done and I was very impressed with it. I don't have research on it, but I do think that if you're having to choose between a normal shoulder placement and reverse, I think the reverse has been showing better results. But I don't think that research is in spinal cord injury because it's not that many spinal cord injury patients getting shoulder replacements. But in the able-bodied or relatively able-bodied, I guess you would say, population, they are showing somewhat better results, is my understanding, than a classic shoulder replacement.
Okay, yeah, I was trying to get more information on it. I've had a talk with on this, and one of the problems the doctor mentioned was is the concern that the socket may not hold with the way in paralysis, the way we use the shoulder, the movement, and the lifting. So
yeah, and I just haven't seen it in a wheelchair user, so I can't comment on that. So I mean, it seems like a legitimate question, and I just don't know enough to be able to answer your question, unfortunately.
Okay, I thank you very much.
You're most welcome.
Thanks, Helmut. Guy?
Now, one question for Tova. In the stretching, it said to hold it, the stretch for 30 seconds.
Yeah, that's just a general guideline, yep.
Yeah, I've heard up to, if you hold it less than a minute, then it's not as effective. Is that...
The research on that is very all over the place, I guess is the easiest way to put it. We say 30 seconds and you can repeat it a couple of different times. The only reason I don't like holding it for too long is that you may not notice that you're starting to get like, it's actually kind of hard to hold yourself in the right position in some cases. So I would suggest that the research doesn't have an answer on exactly how long you need to hold it. Certainly 30 seconds seems to be the minimum. And just for compliance, that's what we use. Because it's hard to convince people to hold it for long times. But yeah, I would say that the research doesn't have a good answer for that.
And I just had one comment for Jeff and his question in turning in bed. If you're turning yourself independently, Jeff, one of the things that I use to turn is made by a company called Preblon. It's called a turn assist. So it's really a slippery material and easier for a caregiver to turn. So, simply something like that to turn yourself might be worth a shot.
Awesome. Hold on, Jeff. I think you're
Good
on
idea.
mute. Hold on.
Your sheet, like is that what it means?
It's like say that again, Jeff.
Slider sheet.
Yeah, it's a whole system, so it covers your whole mattress.
Oh yeah, I've got one.
You got one?
Yeah. Oh yeah.
I'm still having trouble.
Oh yeah.
Yeah.
It's poor education on my part.
Yeah.
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 Okay.
Easy to say in the day, but in the middle of the night, sometimes it's hard to do the right thing.
Yeah.
Okay.
Awesome. Thanks, guys. Let's see. Who else do we have here? Aaron, anything from you?
Sure. I just wanted to say I have a pre-existing condition with my shoulder. A bit of a click. Anytime you raise it over the shoulder point there. We've addressed it before. We've tried stretching with it. I know you're saying stray away from the surgery. It doesn't affect my wheeling at all, but it's definitely something that I'm concerned about down the line.
Yeah.
I'm just asking if there's anything that I could possibly do to try to help it.
Yeah, I'm not sure if I know exactly what the problem is, so I'm not sure if I can answer your question. I tend to tell, sorry, go ahead.
No, go ahead.
I tend to tell people if you have clicking and popping, if it's not associated with pain, kind of don't worry about it. It's not necessarily a sign that something's wrong. It's just what we know is actually did some research recently, and they found that the popping that you notice in your joints is actually just from nitrogen bubbles actually popping when you pull on the joint in a certain way. And if you really want to nerd out, there are videos of that online. But it's that's what you're hearing when you pop you're like you crack your knuckles, or you do some funny stuff with your neck, those sorts of things. So I tend to tell people if there's no pain associated with it, it's not necessarily a problem. And the same would go for clicking. People during your original injury or on an injury after that, you may have caused some types of damage. But if it's not causing you discomfort or pain, I would just suggest that don't try and fix something that's not actually causing you trouble.
Perfect. All right. Thanks, Tova. And it was a great presentation.
Good.
I think that's about it. I have kind of a comment, question. I don't know. It's kind of hard to ask this, and I know I don't know. It's just a weird thing. Anyways, some of us like Tova and myself and Rod and Terry were at this conference over this last weekend here called Working to Walk. And one of the things that many people who have been living with spinal cord injury for many, many years has said over the years, okay, we don't really care about walking, but fix our bladder, bowel, hand function, those kinds of things. Those are the things that are most relevant to us, right? And it kind of got me thinking to this whole trying to minimize transfers. Because if all of a sudden our bladder bowel is fixed, now we're going to have to do even more transfers, right?
Good point.
How is that good? Are we not going to have kind of a combination of mobility along with this? I mean, and I'm talking about sort of these stimulators that they're putting in people, and it just it doesn't seem to be the end all answer, even though it would be great to have and make our lives easier, obviously.
Yeah, I was thinking about that because somebody was mentioning that people who have gone through the stimulators, who are doing some standing, have noticed that they are having more shoulder pain because, of course, you have to use your arms a lot to help your legs, which are just coming along. So everything has an impact. Every action has a reaction. So I think that's a really good point.
Yeah, I know it's kind of an interesting thought, anyways. But great information. And that's really about it, I guess. Thank you so much, Tova. That was amazing.
Thanks, Tova.
Thank you.
Thank
Yeah.
you.
No problem.
Thanks, Carrie.
Thank you, guys. And we'll see you again at the next one.